But evidence is starting to come out that we know very well that patients that are put on modified diets or thickened liquids, they generally do not like it. It impacts their nutritional status, impacts their appetite and the calories they take. Also, I do want to mention, I'm not sure how many people are familiar with Protocol 201, but this was a NIH-funded trial that looked at the management of thin liquid aspiration in patients with Parkinson's disease, with or without dementia, or dementia patients. And I had the opportunity to work as an investigator, a co-investigator with Dr. Robbins and Logeman on this. And what the data showed us with that is that patient, even though thicker may have eliminated that aspiration in the radiographic suite, oftentimes urinary tract infections and dehydration were more common on patients on thickened liquids. Why? Because of the thickened liquids? No, generally because patients didn't like them and rejected them. And also the average length of stay because of pneumonia was 3 times longer for patients that were drinking honey-thick liquids compared to those who were either placed on a nectar-thick liquid or just using a chin tuck. Why? Probably because we've got to remember that eating or swallowing is an endurance task. So if the patient fatigues over the course of a mealtime and they aspirate the thicker honey, they probably have a greater difficulty in clearing it from the airway. So again, we need to think about the recommendations we make. Thickened liquids may be helpful for a short period of time and they may be necessary, but we need to think of the potential long-term consequence and evaluate that in patients. Again, I encourage you to pull this article. It appeared last year in the ASHA Leader. And Medicare came out with a statement saying that they found little benefit from modified diets, tube feedings, and dysphagia diets. And they clearly stated unless a medical condition warrants a restricted diet, they recommend considering beginning with a regular diet, seeing how the person does, and then make modifications from there. At this point, what I'd like to do is want to talk a little bit about the top 10 end-of-life considerations. And let me tell you how this came about. This was a presentation that I co-presented, a portion of it with my colleague, Dr. Donna Lundy at the University of Miami, and we sat on the phone for a number of hours one night and talked about a lot of the typical challenges that healthcare practitioners, speech-language pathologists face in different care settings when they're dealing with the frail elderly or the medically fragile. And we're going to go step by step and kind of give you some of our thoughts and ideas in terms of dealing with many of these questions. Some of them are supported by the literature. Others are by our probably combined 60 years of clinical practice, best practice, and so on. So we're going to talk about that, these top 10 ethics considerations during the remainder of the 2 presentations. And there's one concept here that I would like to really bring your attention to, and that's coercion. And if we think about coercion, it's not simply standing over the patient or the family member and say, you must do this, sign here. Think of the different ways that we can, that family members may be coerced. For example, if we said to the family member, they're going to choke on this diet and you need to put them on this modified diet, that is coercion. We need to educate them about the risk, but again, we don't need to induce fear if they make the decision to continue feeding.